Hi, and welcome back to Abnormal Psychology. In this chapter, we're looking at substance-related and addiction disorders. Throughout the evening of June 24, 2009, Michael Jackson, the entertainer, energetically rehearsed for an upcoming concert series. The next morning, he was found in his bedroom, not breathing. Paramedics could not revive him. His death appeared to be a result of a drug overdose. Now, battling pain, anxiety, and chronic insomnia, Jackson used a variety of pain medications. His addiction reportedly began with pain medication prescribed after he was burned while filming a Pepsi commercial. The details of his later drug use were unclear, but prescription painkillers, stimulants, anti-anxiety, and sleeping medication are often mentioned. Medications became less effective as Jackson developed a tolerance to the drugs. Jackson continued to battle chronic insomnia and was desperate to rest, resorted to an increasingly more dangerous substance. And on June 25, 2009, he suffered a cardiac arrest. The coroner found multiple medications in Jackson's systems, including a powerful anesthetic, propofol, and it was concluded that Jackson's death resulted from an acute propofol intoxication. Now, addiction of alcohol or substance are something that's not new to us. However, they can and do create circumstances by which we can struggle with and be able to participate normally in our lives. So from this example and others I'm sure you might be familiar with in your own lives, let's see how this form of disorder is classified, described, theoretical perspectives and treatment strategies related to substance-related and addictive disorders. So we're going to start with classification of substance-related and addictive disorders, and we're going to do this in a couple of parts, I think. It might turn into 3. The DSM-5 classifies substance-related disorders into 2 major groups: substance use disorders and substance-induced disorders. Substance use disorders involve maladaptive use of psychoactive substances. Substance-induced disorders are disorders induced by the use of psychoactive substance, including intoxication, withdrawal syndromes, mood disorders, delirium and delirium tremors, and even amnesia. So let's review some of these terms. Now, some of these terms we've touched on in mood disorders, and the mood disorder one and the amnesia were covered in chapters 4 and 5. But we will look at some of the other components here, and we'll start with intoxication. Now this is characterized by clinically problematic behavioral psychological changes caused by a recent ingestion of a substance. In other words, it's the state of getting drunk or being high. What intoxication will look like depends on what substance is being used, the dosage of that substance, the person's reactivity, and to some degree, the user's expectations. Extreme intoxication can lead to death. Withdrawal syndrome. This is the characteristics when a person stops a substance that they've been using and they stop it abruptly. After a period of long and heavy use, and then you stop, the symptoms will vary according to the substance used. But often people who are suddenly stopping something they've used quite frequently, they'll start up again. And as the resulting withdrawal can be very uncomfortable, and it relieves the discomfort to begin drinking or doing that drug again. So that's the withdrawal syndrome. With alcohol, withdrawal can include delirium and delirium tremors, or what is also known as the DTs. Delirium is a state of confusion, incoherent speech, disorientation, even hallucinations. Delirium tremors, or DTs, these are usually associated with heavy, chronic users of alcohol who stop abruptly. The DTs involve autonomic hyperactivity. You don't choose to have your heart rate go up. That's the result of this autonomic hyperactivity, and it sweating and delirium. It's very uncomfortable state from what I've understood. Substance use disorders. Now let's look at that more specifically. Now, according to the DSM, substance use disorders involves a pattern of recurrent use of a substance that repeatedly leads to damaging consequences to social, occupational, psychological, or physical problems. Substance use disorders, which often include features of physiological dependence, involves impaired control over the use of the substance. Substance use disorder may continue over a long period and can progress to more severe progressions, even to the feeling of helpless to control their use. Addiction, physiological dependence, and psychological dependence. Now, these are really important terms and ones that can help with treatment. People define addiction in different ways. And for our purposes, we're going to define it as the habitual, compulsive use of a drug accompanied by evidence of physiological dependence. The major signs of physiological dependence involve the development of tolerance or the abstinence syndrome. You may have experienced tolerance if you were prescribed the pain medication after a surgery and you took the medication as prescribed. Perhaps after a while you noticed the medication may not have been having the same effect. This could be, or at least resemble, tolerance. Now, the psychological dependence, now this one is one that can be acting as a trigger in a lot of recovery and treatment, so it's worth bringing it up. Psychological dependence involves a pattern of compulsive use associated with impaired control over the use of a drug. Now, this dependence can be a tricking one, especially with the treatments. We need to get to a point where need to get to a point where physiologically the substance and its effect have cleared our system. However, we may still find hanging out with some of our friends or going to a place that we've always used to go to can be a trigger psychologically to activate our use. That's why in a lot of treatments for substance abuse disorder is to leave those friends and don't go to those particular places you used to go with your friends, because they can act like a trigger and you can start up that same behavior again. It's like those who have stopped smoking, going to a bar or to a restaurant can find that difficult as your friends go out for a smoke or after a meal and you want to go out for a smoke like you used to do, but you can't. So this can be more challenging than you think. So what are some of the pathways that people can use to get to this disorder? Now, although the progression to substance use disorder varies from person to person, some common pathways can be described according to the following stages. The first stage is often the beginning or the experimentation stage. It's the occasional use. You get a temporary, feel good. Users feel in control, believe they can stop anytime, and at that particular time they probably could. This next stage, if you progress through, is the routine use. Now, lives begin to be structured around the pursuit and or the use of drugs. Denial plays a big role here, the covering up. Things that were once important, family, work, and other hobbies, are maybe less so than drugs. Choices are dominated by drugs, spending, strained relationships with family and friends, unexplained absences. And then the next progression, addiction or dependence. Now, this is when the routine user feels powerless to resist the drugs, either for the effects of the drugs or to avoid withdrawal. So drugs of abuse. We're going to have to, we'll look at some of like what are the drugs that are most likely involved with abuse disorder. And here we're going to look at the classification of substances related to disorders. And there are 3 groupings: depressants, stimulants, and hallucinogens. And we'll start with depressants. Depressants are drugs that lower the level of activity of the central nervous system by reducing feelings of tension and anxiety. Causes movements become a little more sluggish and impairs our cognitive processes. In high doses, depressants can arrest vital functions and even cause death. Depressants include alcohol, barbiturates, sedatives, minor tranquilizers, and opioids. The effect of alcohol can include, as we've mentioned, intoxication, impaired coordination, slurred speech, impaired intellectual functioning. And there are risks for people who experience alcoholism. On the gender component of risk, there is equality here, fairly equal in terms of who gets, you might experience alcoholism. But there's some dispute that may be due to when studies were completed. Women started later, but alcoholism moves more quickly for women. The second risk factor is age. Young adulthood before 40, and typically beginning in late adolescence, somewhat later for women. And so those periods of time, establish a lot of life to create patterns. The third is antisocial personality disorder. Antisocial behavior in adolescence or in adult increases the risk for alcoholism later. Family history is a fairly significant one. It's one of the best predictors for problem drinking in adulthood. Now, this could as a result of poor modeling, or it could be perhaps of some biological predisposition. The fifth risk factor is sociodemographic. Now, that's the increased risk from being in lower income and lower educational level contributes to higher risks of alcoholism. Concepts of alcoholism include once an alcoholic, always an alcoholic. Now, this was Jelinek's disease model, and the suggestion here is that alcoholism is never cured. Now, if we look at some of the psychological effects of alcohol, often the stereotypical expectation that alcohol will reduce tensions and worries and increase pressure in social interactions, in fact, can be more detrimental. It's a term that I usually have. It's called short-term pleasure, but there's long-term pain. We want to be able to switch things around to long-term pleasure and short-term pain. Chronic disordered alcohol use has been connected with disorders such as alcohol-induced persistent amnesia disorder, aka this is also known as Korsakoff's syndrome. But another more significant risk that you would be familiar with is cirrhosis of the liver and other physical disorders, and with fetal alcohol syndrome in pregnant women. Barbiturates are depressants or sedatives that have been used medically for relief of anxiety or short-term insomnia, among other uses. Now, they can become psychologically and physiologically dependent, both in terms of tolerance and in the development of withdrawal syndrome. Opioids are narcotics such as morphine and heroin and are derived from the opium poppy. Others are more synthesized. Used medically for pain relief, they are strongly addictive. The disease model treats problems of substance abuse and dependence as a disease process. Now, stimulants, our second group, these increase The dependents decrease the central nervous system activity. Stimulants increase the activity of the central nervous system. Psychoactive substances like amphetamines and cocaine increase the availability of neurotransmitters in the brain, heightening states of arousal. High doses can produce an amphetamine psychosis, which mimics features of paranoid schizophrenia. Cocaine, which is produced from cocoa leaves, is snorted as a powder or injected as a liquid. It's known as freebasing, or smoked in a hard rock form. It's known as crack. Cocaine produces a high by stimulating the neurotransmitters dopamine, resulting in a rise in the blood pressure, accelerated heart rate. Overdoses can include insomnia, restlessness, and nausea, tremors, hallucinations, and even death. Repeated use of nicotine, usually in the form of cigarette smoking, can lead to physiological dependence. I don't think we need to go too much into nicotine, as it's been a long time issue in society that we've been chatting about. Hallucinogens, as our third group. Hallucinogens, also known as psychedelics, are a class of drugs that produce sensory distortions or hallucinations. Hallucinations involve major alterations in color, perception, and hearing. Hallucinogens may also have additional effects such as relaxation and euphoria, or in some cases, even panic. Hallucinogens include LSD, psilocybin, and mescaline. Other drugs with similar effects are cannabis or marijuana and PCP. There is little evidence that these drugs induce physiological dependence, although psychological dependence may occur. LSD is an acronym for lysergic acid dithiamide. It appears to decrease the serotonin action and increase the dopamine activity. Flashbacks or re-experiencing of some of these distortions from a trip can happen days, even months, even years after use. They are sudden and are a result of chemical changes in our brain. PCP, or phencyclidine, it began as an anesthetic back in the 50s. And it was discontinued when it discovered it had hallucinatory effects. Very unpredictable effects, which can increase a heart rate and blood pressure, but is also capable of producing delirium. So it was really not a good medical use. Marijuana has a psychoactive ingredient called delta-9 tetrahydrocannabinoid, or THC. The proportions of marijuana users in Canada is much higher among young adults than in the population as a whole. Dependence is associated with psychological and physiological dependence. Next, we can look at inhalants. Inhalants are substances that produce chemical vapors that are inhaled for its psychoactive effect. Many substances can produce fumes which, when inhaled, can induce feelings of intoxication and euphoria by their actions on the GABA and dopamine systems. The psychological and physical effects of inhalants can be very serious and can even be fatal. Now, I know this was a quick overview of the classifications of substances. Next, we're going to consider the theoretical perspectives in part 2. All right, everyone. We'll see you in part 2. Bye.